Good day to Dr. Mahanis. We are from Group 4 Team A, going to present our ambulatory care case.
My name is Amira and I'll be describing a little bit about the patient's information. So the patient's name is Tan, an 81 years old Chinese male patient with BMI of 24.22 kg per meter squared, which is considered as normal. He was coming to the hospital for follow-up on his joint pain condition and currently used the walking stick. He has also diabetic mellitus, hypertension, dyslipidemia, and osteoarthritis for 2 years. He's now taking paracetamol, amlodipine, perindopril with indapamide, metformin, and also lovastatin. There were no family history stated, and there were no known drugs allergy. For a drug-related problem, patient complains that the paracetamol is not effective to manage the pain due to osteoarthritis. We would like to suggest to add topical NSAIDs to manage the pain, as paracetamol and topical NSAIDs is the first-line therapy for OA. We would like to suggest to change to walking shoes with neutral and contact orthosis as recommended in the CPG guidelines.
For osteoarthritis, the goals of treatment included to relieve symptoms and to improve joint function. The first-line treatment recommended for osteoarthritis is paracetamol and topical NSAIDs such as diclofenac gel. From CPG, topical NSAIDs may be offered in the treatment of osteoarthritis and can be an adjunct or alternative to oral NSAID. From NICE guideline, it's appropriate to consider topical NSAID or paracetamol ahead of oral NSAIDs. Also, considering that our patient is elderly patient, topical NSAID offers the similar efficacy as the oral NSAID and they have better safety profile. The risk of gastrointestinal, renal, and cardiovascular toxicity is 5 to 17-fold lower with topical NSAID. Besides, the concurrent use of ACE inhibitor and oral NSAIDs may result in renal dysfunction and increased blood pressure. So in this patient, the recommended treatment for osteoarthritis is paracetamol and topical NSAID.
For hypertension, the goals of treatment is to achieve systolic blood pressure target of less than 150 mm mercury and to reduce risk of all-cause mortality, cardiovascular mortality, and also cardiovascular events. The past medication history are as follows: amlodipine 5 mg OD and perindopril 4 mg plus indapamide OD. Moving on to the justifications, the use of amlodipine has no significant adverse metabolic effects and glycemic control in diabetic patients are not compromised. ACE inhibitor also has no adverse effects on lipid and carbohydrate metabolism in diabetic patients. Also, single pill combination of perindopril with indapamide has been reported to reduce overall mortality. As seen in the accomplished trial, the efficacy and safety of the combination of ACE inhibitor and CCB results show fewer cardiovascular events compared to the combination of ACE inhibitor and thiazide diuretic. According to the perspectives of advanced trial, the addition of CCBs to the combination of the ACE inhibitor perindopril and the diuretic indapamide seems to enhance the reduction of all-cause mortality and heart cardiovascular outcomes in patients with type 2 diabetes. Interestingly, these potential benefits were seen without any detectable increase in adverse events.
For diabetic mellitus, the goal of treatment would be to achieve the appropriate glycemic level. So for this patient, the targeted A1C level will be less than 8%. This is because the patient are having osteoarthritis, so somehow the patient function are impaired. And also we have targeted the A1C level a little bit higher to reduce the risk of hypoglycemic event and also risk of fall. Next is to reduce the diabetic complications such as micro complication and macro complication. And lastly is to improve the quality of life of the patient. So for this patient, he is receiving metformin 1 gram BD for his diabetic mellitus. So according to a few guidelines such as CPG and also American Diabetic Association, the first line treatment would be metformin. This is because metformin can reduce the A1C level by about 1.5%, which means that metformin can achieve a higher A1C level reduction compared to other oral anti-diabetic agents. Besides, it also has weight stabilization property, which the patient are less likely will cause weight gain. Lastly is its safety profile, which is less likely to cause hypoglycemic event. So the dose of metformin this patient receiving is matched with the recommended doses in CPG and also MIMS. So I conclude that the management of diabetic mellitus for this patient is appropriate.
Based on CPG, the patient is classified as a very high cardiovascular risk individual with the target LDL cholesterol levels of less than 1.8 millimole per liter. He is on lovastatin 20 mg on night for 3 months. Statin therapy is recommended for older adults, particularly with hypertension, diabetes, and dyslipidemia. It is proven to reduce major vascular events in different trials regardless of the baseline levels or characteristics. Very high-risk individuals should be treated with maximum appropriate statin intensity that does not cause adverse effects. At the same time, it should be started at lower dose and titrated upwards to achieve the target lipid levels due to comorbidities and altered pharmacokinetics in the elderly patients. Lovastatin 20 mg on night is appropriate considering patients' old age and the need to titrate from low dose. However, atorvastatin 10 to 20 mg on night is actually a better choice for this patient. International guidelines generally recommend moderate intensity statin, specifically atorvastatin 20 mg for patients with diabetes and older adults. Unlike lovastatin, atorvastatin is widely tested among the elderly and is proven to be the most potent statin with improved clinical outcomes. The ASCOT and CART study also proved that low-dose atorvastatin can reduce cardiovascular events and mortality in both hypertensive and diabetic patients. Atorvastatin also showed significant greater reduction in LDL levels than lovastatin. Besides, the alternate day dosing of atorvastatin is also effective if patients could not tolerate statin-associated side effects. The overall risk-benefit ratio of atorvastatin have more favorable cardiovascular outcomes than lovastatin in elderly patients.
I'm Amira, and for pharmacist intervention, one of it would be patients' education for the management of OA to make sure that this patient understand about their own condition, as well as to encourage positive health-seeking behaviors that can improve patients' self-management and outcomes. We would like to encourage for lifestyle modification through healthy diet as well as through physical activity. For healthy diet, we would like to advise the patient to take diet high in fiber, fruits and vegetables, whole grain, low in salt, and saturated or trans fat to lower the risk of having cardiovascular disease in a patient with dyslipidemia. We would like to recommend a quarter half plate diet, as well as to advise the patient to limit dietary cholesterol as well as the sodium intake. For physical activity, considering the age and condition of the patient who are using stick to walk, high intensity exercise seems to be less appropriate to be recommended. We would like to advise the caretaker to monitor and help patient to carry out the activities of daily living which are possible with care. Next, we have to address about the side effects of the drugs and provide some advices so that the patient will know how to initiate early management if any of these side effects occur, such as to advise the patient not to operate any machinery or vehicles after taking amlodipine if there is symptoms of dizziness, fatigue, or nausea. For perindopril and indapamide, which can cause dry cough and orthostatic hypotension, we have to tell the patient to at least remember the name of the drug, so that when the symptoms of dry cough occur, an appropriate recommendation of medicine can be given. We also need to advise the patient to sit or lie down before use and get up gradually to minimize the effect of orthostatic hypotension, which is presented by sudden headache or lightheaded after standing up. For lovastatin, long-term use may cause muscle ache, and we have to advise the patient to inform the physician if these symptoms occur. Besides, we need to encourage on self-monitoring of blood pressure and blood glucose at home. So we should inform the caretaker to record the data and regularly do the self-monitoring at home. For efficacy and safety, we have to monitor the effectiveness and also the safety of the pharmacological therapy. And last but not least, we would like to suggest supplementation, such as glucosamine sulfate 1500 mg per day to the patient.
Lastly, for the monitoring parameter, tablet amlodipine and tablet perindopril plus indapamide was being used to control the blood pressure levels. According to the CPG Management of Hypertension 2015 recommendation, the target systolic blood pressure for patients aged more than 18 years old is less than 150 mm mercury. In use of the amlodipine, we need to monitor signs of peripheral edema and signs of hypertension such as lightheadedness, blurred vision, and nausea. While for the tablet perindopril, we need to monitor the serum electrolyte levels, signs of hypertension, and the signs of the dry cough. For the type 2 diabetes mellitus, tablet metformin was used to control the blood sugar levels. The reasonable target A1C is less than 8.0%, and the preprandial range target is 5.0 to 8.3 millimole per liter. As this medication associated with high risk in GI symptoms, thus we need to monitor the gastrointestinal function. For the dyslipidemia, tablet lovastatin 20 mg was being used. We need to monitor the lipid profile, include triglyceride less than 1.7 millimole per liter, HDL cholesterol more than 1.0 millimole per liter. As patient is very high CV risk, thus the LDL cholesterol target is less than 1.8 millimole per liter. For the safety monitoring, we need to monitor the signs of myopathy and monitor the liver function profile. Lastly, for the osteoarthritis, tablet paracetamol was being used. We need to assess the severity of the pain, for the effectiveness, and for the safety monitoring, we need to monitor the signs of any hypersensitivity reaction. Thank you.